If it's okay with you, Suki, I'm going to move on to impetigo. Okay. So with impetigo, and if you can bear with me for another 10, 15 minutes, I'll be grateful because we're getting to the good stuff as well. All right. With impetigo, we know that it's super contagious. Okay. We know that it affects the outer dermis of the skin, the epidermis area. And it's mainly caused by bacterium Staphylococci. The diagnosis of this tends to be clinical, but also you need to consider patient's history in terms of what you found during the physical examination, in terms of what's happening, where else do they live, who else can get it, in terms of close contact and so on and so forth. We have two types of impetigo. One is non-bolus and the other one is bolus forms. The non-bolus is the more common form, okay? And it's more common in times of late summer and often found in what we have in preschool children as well as young adults. It's usually associated with poor hygiene and skin conditions such as eczema and dermatitis and such, which can lead to a break in the protective layers, okay? What do we see when we see individuals with impetigo? Well, when we look at the non-bolus one, we find the following clinical features: that they might have the initial lesions as thin-walled vesicles or pustules, okay? And these can rupture quite quickly. These release or exudate to form the characteristics of the golden crust or brown crust around the periocular area or around the nasal area. And once these crusts have dried, they can sometimes separate. So in the bottom picture, the crusts have been removed, causing a red erythema, which then generally fades. And healing usually occurs spontaneously without scarring, within 3 weeks or so. The lesions can also occur anywhere on the body, but they tend to occur mostly in the face, in the most exposed areas, such as the perioral, the perinasal, limbs, and fixtures as well. And we may also see patients asymptomatic, but they usually are quite itchy or mildly itchy. So you find kids just scratching away at them as well. Okay. When we're looking at our PGD, now our PGD does not cover bolus. Okay, it only covers non-bolus, but it's important to see the difference. So this is the bolus impetigo, and these appear as a flaccid fluid-filled vesicle and blisters, and it often is about 1 to 2 centimeters in diameter. It can be around for about 2 to 3 days. It usually blisters, leaving a very thin, flat brown crust on top. Healing occurs quite quickly and usually occurs within 3 weeks without any scarring. But the lesions can also occur in anywhere in the body, like we said, as with non-bolus impetigo. Bolus impetigo may particularly be more widespread in infants compared to any other age group. So it's something that we need to address, but our PGD does not cover it, but it's important to see the signs and see the difference. I got this from Red Whale, really awesome resource. The red flags for impetigo is anyone with serious illness, anyone who's immunocompromised, anyone where infection is also present, okay, and also bolus impetigo as well, okay. And this is where we might need to use News2 scoring to identify and address these patients going forward. When we're looking at our history, again, ask about clinical features, see what you say, write it down, okay, but identify fevers, rigors, if they're immunocompromised or if they've had recurrent impetigo. Now, recurrent impetigo specifically is defined as having 2 or more episodes in the same year. If they do, red flag, not your job, pass it on. But also find out other things like what's the history, have they had it before, how many times they've had it, who else has had it, okay, what does it look like, what are the symptoms, okay. And also, what's their social sort of standing, sexual history, who else has got it in the family as well, okay, going forward. Just gives you a bit more narrative going forward. So if, for example, you don't have any red flags and the exclusion criteria is not met, then we now need to look at differential diagnosis. And this is where we need to see what the non-bolus impetigo looks like. And we mentioned about lesions, thin walls, ruptures, the exudates dry, golden yellow crust being formed, which thickens, comes off, leaving a erythematous red patch, which usually heals within 3 weeks. Okay. If any of those aspects occur, then yes, it's more likely to be impetigo, and that's where you get your gateway points. If it doesn't, it's likely to be something else, then in which case we need to refer onwards going forward. In terms of treatment pathways, okay, treatment pathways, we are differentiated by two different ways. One is, oh, I think Suki's trying to admit herself. 1 second. There you go. We're looking at two different pathways. We look at how do we manage localized non-bolus impetigo, and that's for people with fewer lesions or fewer. And we tend to give things like hydrogen peroxide to apply 2 to 3 times a day for 5 days. And if it's ineffective, then we can consider using fusidic acid. For those individuals with more widespread, and this is considered obviously with people with 4 or more lesions, okay, then we may consider individuals for antibiotics, Fluclox for 5 days. If they got penicillin allergy, then clarithromycin, or if they're pregnant, they might give erythromycin, okay. But for all people with impetigo, we need to make sure that we provide them with information and advice about self-care, but also about good hygiene, reducing the spread, making sure they're not sharing towels, not sharing sippy cups, okay, and having that sort of awareness about general maintenance and hygiene. Oops, there you go. And making sure that for patients and for all patients that, there is a BAD leaflet available, a British Association of Dermatology Impetigo leaflet that will give them a bit more awareness about what to do and how to maintain and manage themselves going forward. And that's the QR code for such. This is we already mentioned about the hygiene, so I'm going to go through that. When do we need to refer? Well, I guess, again, like with all the other conditions, if they become very seriously unwell, if they're already immunocompromised, especially with widespread impetigo and immunocompromised patients, but also recurrent if they got bolus, especially those who are under the age of 1, if they're systemically unwell, and also high risk of complications. Yeah, cool. Any feedback? I'm going to actually move on to infected insect bites. So if there was any questions, we'll leave it until a bit later, just because I've got some juicy bits that I want to keep for you shortly. So infected insect bites, okay. This is a bit of a difficult one because obviously it depends on where you are working, what exposure to green leafy areas you've got in terms of forests, in terms of woodlands, in terms of marshes, and so on and so forth. And also, if there's any patients coming from overseas who may have contracted something or picked up something or been bitten overseas and then are presenting to you and you may not be aware. But we know there are different types of bites, okay? Insect bite, different types of bites that we need to address, as well as stings as well, okay? But what do we do first? We get rid of the red flags so we don't mess around with them, identify them. So anyone who may have hypersensitivity, anyone who might have severely immunocompromised or signs and symptoms of an infection, or who are immunocompromised, but also where a patient has been stung and maybe at risk of having airway obstruction. So it could either be in the mouth or the throat or around the eyes of causing orbital cellulitis, which needs to be addressed. You can't deal with it. I can't deal with it. It needs to be addressed through A&E. And again, utilizing News 2 scoring, especially if they are severely unwell. But we have got different types of bites and stings, and we know that some insects like mosquitoes, bedbugs, and fleas, they got little mouth parts which pierce the skin with a little bit of trauma from the bites, and these insects may not always be noticed by the person being bitten straight away, whereas other insects like horseflies and midges, I don't know if you've been bitten by these insects, but you will feel their mouth parts. They don't have mouth parts, but what they do is they take your blood by lacerating the skin and lapping up the pool of blood in the wound, okay? And these tend to be more painful. They tend to be noticed immediately by the person being bitten. And we also know that certain insects, as part of their ability to lap up the blood, they use things like anticoagulants and also vasodilators in the saliva during feed to ensure that blood is flowing freely into them and that it's not stopping. Sometimes there might be antigenic sort of compounds in the insect saliva, which can lead to local skin as well as inflammation around that area, which is what we may be allergic to, or we may have sensitivity towards. And we find also there are different types of exposures where we might build up an allergic a reaction towards something, depending on the type of exposure to or hypersensitivity towards that component of that insect bite. We also know that stings such as honeybees, bumblebees, wasps, and hornets, they sting by injecting a venom uh, from a sac attached to a barbed or a stinger, which goes directly into the skin, and this is usually immediately painful and noticed by the person being stung. Occasionally, honeybees, for example, might leave the stinger attached to the venom sac onto the skin after they've stung. Okay, and venom also sometimes contains allergens, which are pharmacologically sort of active substances that cause reactions and allergic reactions, which might be presented as mild localized pain and erythemas in that area. Okay, so it's important to identify, from a history, what do you feel you've been bitten by or stung by, and what are the sort of puncture points in that individual, Of course, you might see also bites from spiders, for example, which are quite direct with two puncture points, as opposed to one puncture point with some other insects. And again, we identify those patients at highest risk and patients who may need to be addressed pretty promptly because of allergic issues or anaphylaxis. And again, utilize the new score and keep the patient monitored before A&E comes. What do we do when a patient comes in? Well, why have they come in the first place, of course, but any rigors, fevers, difficulty in breathing, are they immunosuppressed? Do they have any recent travel? And also, do they have any serious reaction to insect bites? If any of these 6 things are addressed at the very early stages of that consultation, it's not your job. That new person needs to be seen by somebody else. Okay. But then if not, then do continue, find out the onset, signs and symptoms, risk factors, who else witnessed the exposure, because not always we might notice that person being stung, or you might notice that that person is stung unless much more afterwards, but someone else might have seen it. And also serious interactions or reactions that the person may have addressed. And from our point of view, when we're looking at individuals, how quickly a reaction might be occurring, how unwell that person's become, are there any signs and symptoms of an infection through pain, discharge, inflammation, smell, or systemic illness that the person's now demonstrating? What's the nature of the rash that the person's demonstrated? And also looking at any other comorbidities that might worsen the patient's outcome as a result of those comorbidities should also be in your narrative going forward. The exclusion criteria from our point of view is any bites or scratch caused by an animal, bites caused by a human, bites caused by a tick in the UK, which would be a sign of Lyme's disease, which is usually seen as a bullseye rash, okay, erythema migrans. Any bites or sting that occurred whilst traveling outside the UK, that could be of concern because it could bring back, insect-borne diseases like malaria or tick-borne encephalitis. And also those individuals who have been stung or bitten by an unusual or exotic insect, which is not common to that area that the person has been. Okay, we also need to identify individuals who have been at least 48 hours after the initial insect bite. If it's been 48 hours, then we might have addressed them. If it hasn't been at least 48 hours, then we would address, as long as they're safe, we'd advise them to be looking after themselves through self-care, through creams, through tablets, through antihistamines, and so on and so forth. We have to also find out, is itch the principal symptom that the person is complaining of, okay, in the absence of any other signs or symptoms or infections? Is it just the itch? If yes, then the infection is less likely to be present. So again, self-care. If the itch is the principal symptom, okay, but there are other symptoms as well, such as the onset of redness of the skin, pain and tenderness in the area, or swelling of the skin or surrounding area, then there's a chance that if 3 or more of these assets are being ticked, then it's more likely to be an infected insect bite, okay? And then you look for any other sort of presentation in terms of redness, in terms of swelling, as well as any sort of pustular discharge from the point of entry. And if you get these, then it's very likely that it's an infected insect bite, and thereby you pass your gateway point going forward. And here's an example of such an example of redness, swelling, and you can see at the point of where the person has been bitten, there's pustular discharge emanating from that area, and it's widespread. It's not just localized to that small area. It's gone further beyond that area that the person's been stung. And there are so many different types of presentations that a patient might present to you with different types of stings and bites. So the first one, as you can see, is a bee sting, a honeybee sting, where the sac and the barbed sort of area has been still attached to the person's skin. Okay, and these obviously may be visibly removed and can be removed quite easily. Okay, then you might get a flea bite. Okay, and these are usually bites from cat or dog fleas, typically found below the knees because of where the cats and dogs are usually. Then you might get, for example, bed bugs, and then where you get micropapular lesions with sort of the different various sites of bites on that area, and they might appear on exposed skin about 10 days after the bite originally from the bed bug. But you'd also look at other sort of presentations like, are they itchy? Do they have any sort of redness, rashness, urticaria and whatnot? And also large number of bites can also lead to widespread inflammation and urticaria, which may be outside the area which the person has already been exposed to. You might also want to consider and suspect bed bugs in patients who are sharing the bed or traveling together and may be getting it from each other. Okay. Tick bites. Okay. The tick itself might be visible in the skin. Now, these ones is outside the remit of our provision, but it needs to be addressed quite rapidly. It needs to be removed immediately, and usually what they do is take a credit card and swipe it across so that they're able to remove the tick in its entirety, including the mouth parts, because the risk is if you try to bring it out and part of the mouth part still remains embedded into the skin, then you increase the risk of furtherment of infections. And usually bites from infected ticks may result in Lyme's disease as well, causing that sort of bullseye rash that you can see there. Okay, you might also get horsefly rashes. Okay, and horsefly and stable flies are painful bites which may bleed, but like I said, it causes lacerations on the skin and they lap up the blood. But it also has an increased risk of secondary infection. You might also get midge bites as well. And these are typically small lesions on the exposed skin, and of course you get spider bites as well, which tend to be seeing that you can see two clear visible puncture wounds, okay, of that individual. So see what you say what you see, and also the history, because you're not there to always witness the type of insect that might still be there or what's been left as a remnant of a bite. Then you need to get an appropriate history from that individual. Now, of course, self-care is the biggest sort of provision, ensuring that as per NICE guidelines, we want to treat infected bites, we reduce the risk of cellulitis. What the NHS and the GPs might do, they might swab the patient, they might advise on symptomatic sort of management using antihistamines, and reassure them that, individuals tend to get better after, 7 to 10 days of being bitten. Okay, and safety net these individuals and make sure you write that narrative into your consultation that these individuals have been safety netted so that they can be addressed appropriately going forward if it gets worse, if they become systemically unwell, or it hasn't resolved post-treatment. Okay. And of course, basic things in terms of washing hands and making sure the area is clean, making sure that, they've got first aid measures available, paracetamol, ibuprofen if appropriate, and the utilization of antihistamine creams. The only time you might not use antihistamine creams is if the person's been exposed to a caterpillar, which I think occurs every autumn time in the UK, and their stingers at the back can spread around the body if you use a cream, and that could actually worsen the person's outcome going forward as well. Okay, so back to the actual pathways. Okay, we know with insect bites, if it's red, it's swelling, it's pustular discharge. Okay, we've got to make sure then we provide the patient with appropriate sort of pathways going forward, that they may be able to get antibiotics. But we've got to exclude anything else, that if they got red swelling and pustular discharge, is the patient well generally in themselves? Okay, is there any other known comorbidities that can worsen the outcome of that individual? Severe pain that is out of proportion of that wound, which might include things that are present in the blood, such as toxin-producing bacteria inside the blood as a result of that bite or sting? Or do they have a collection of pus or fluid at the site of infection, where it might require drainage, which is obviously not your job? If none of those aspects are present, then yes, they would be appropriate for fluke clogs, or allergic, they can use clarithromycin, or if they're pregnant, they can use erythromycin. If they have got those aspects, then they would need to be referred. Safety netting for these individuals. Okay, again, very top line, making sure that if it doesn't get any better, if they become systemically more unwell, then they need to be seen pretty promptly. And if the area around that area that they got bitten becomes red, painful, swollen, of course, the risk of DVTs and risk of other sepsis and such could be a higher risk, especially if the temperatures are high of their swollen glands as well. Okay, so make sure you are addressing them appropriately. From a safety pet measure point of view, okay, skin's covered, avoid wearing brightly covered flowery prints or anything like that. Don't look like a flower, don't smell like a flower, okay, and making sure that walking barefoot in sandals should be avoided. No having strong scented perfumes, avoid areas of greater risk, and ensuring that they use appropriate insect repellents that's in date, okay? Okay. So this is the juicy one as well. I like this one. So Helen will like this. Helen from Timpa, hope you're there. Okay. Please don't correct me if I'm wrong. But no, you can correct me. Correct me if I'm wrong. Correct me if I'm wrong. Okay. So, so we know the whole apparatus of the ear is absolutely exquisite. There's divinity in design in terms of how we capture sound waves and getting it moved into the actual ear canal and then moving it onto the tympanic membrane for it to be then converted, utilizing the internal inner ear mechanisms, to electrical impulses that we would then perceive as sound. Okay, and we know while the external and middle ears are mainly concerned with the transmission of sound, the inner ear, which contains a cochlea, often called the organ of hearing, okay, also houses the other organs, such as the organ for balance as well. So let's have a look at just maybe the top two sections, the outer ear and the middle ear, which is pertinent to what we do in pharmacy first, okay? So what do we do when we're looking at our outer ear? Well, we need to look at the actual pinna, okay, which is, before we even dig deep into the actual ear canal, we need to look at the outside, okay? And we know that the pinna is actually like a big satellite dish. Would you say it's a satellite dish, Helen, trying to receive all that information, okay, and diverting it into the ear canal itself? It's a flexible, elastic structure, okay? It's also good, beneficial for protection because it will bend rather than stay rigid, okay? So it's made of cartilage, okay? It's a continuous sheet of cartilage. And sometimes that in itself can cause a problem because that continuous sheet of cartilage can be damaged either through physical trauma or through infection, okay? And we've seen this in patients who engage with, like, physical sports like rugby, boxing, MMA fighting, where the distortion of the actual pinna is quite evident. And to recap, okay, so we've got, what do we see here? And I hope you guys can move your finger to the areas of concern, because that's what you'll need to know when you look at the landmarks of the ear. You've got the outer helix, okay, which is the outer fold. And then inside that helix, just underneath, you've got that antihelix, okay? The other area I would like you to touch is your targus, which is just adjacent to the ear canal itself, okay? And opposite the targus is the antitargus. Right at the bottom, you can feel your earlobe, lobule, okay? Mainly fatty substance. A lot of people get that, obviously, pierced, okay? But the consistency of the ear changes in functionality as well as form as you move from top to down, top to bottom, okay? Now, when we're examining, especially in kids, okay, it's important to review the presence of the different sinus areas, okay, especially around the periarticular sinus. So if you put your finger where your target is and move away from the ear, you have your lymph nodes where your periarticular sinus is, okay, and these usually add extra narrative to say if this is raised, if these lymph nodes are raised next to the target, then it usually adds narrative to the presence of having an infection. And as a result of that, it'll give us more narrative when we're writing it down on our clinical notes. We don't only just look at the pinna, the ear itself, we also move behind the pinna, okay? We look for any scars, okay? Look for any scars behind, but also we're looking for any inflammation as well, especially around the mastoid bone. And we see any inflammation, we usually call it mastoiditis. Serious infection, super common in children, usually caused by acute otitis media. And so once you've examined the skin around the area as well, and look for any skin lesions, check for color, and check for any sort of deformities, then we start looking inside the actual ear canal itself. So what do we do? Now, most of us will have this simple tech, not what Helen's got with that high-tech sort of otoscope. Our otoscope, pretty standard, okay, utilizes fiber optics to emanate a ray of light into the actual ear canal onwards, okay, and we see it through a visual piece, okay. Now, the visual piece, we're supposed to have at least ×3 magnification, okay? Sometimes you can get a bit higher, but to be honest with you, ×3 magnification seems to be about standard in terms of what you can get from Amazon. When we're looking at the ear canal, okay, it's important that we don't have to delve straight in because it's such a narrow environment. We need to make sure we look around the ear canal. We check for infections, we check for inflammation, we check for any debris, we check for any foreign objects, okay? Can we look at the actual membrane around the ear canal itself? Now, we know with the ear canal, if you start looking into it, you can see at the bottom picture that the first 1/3 of the ear canal is a continuum of the actual pinna itself. So it's cartilaginous based, okay? So it's quite soft, it's quite maneuverable. But as soon as you move into the third, and the third part of the actual ear canal, it's based on bone and it's based on a very thin membrane. So any sort of movement can be felt quite significantly by the patient that you're examining, okay? So it's important that we are utilizing our otoscopes appropriately, but we're not leaning on the patient going forward. Because of age and because for adults, as we get older, our ear canal tends to meander like the riverbeds of Knoxborough Lake and such. It tends to meander. We need to manipulate that ear canal by using the other hand, as you can see on the top picture, to lift up the actual pinna to straighten out the actual ear canal. Now, for children, you don't have to do as much because they don't have as much meandering of the ear canal compared to that of adults. So all you need to do is push it back. Whereas for adults, you need to push it up and push it back, okay? And this helps straighten your line of sight when you're looking down the ear canal. So once you've examined, like we said, the skin around that ear canal itself, okay, we can then see what the ear canal is presenting, and like we said, infections, inflammation, debris, or anything, foreign objects. It's important that we use the right speculum size for this patient in front of us. That comes in 2 main sizes, adult and child. But remember, in some adults, you may need to use child, and potentially some children, you might need to use an adult size because of the actual diameter of the ear canal is about 0.6. If you use anything larger than the patient's ear canal, you're going to cause pain. You can increase the risk of infection, okay? So make sure you use the right speculum for the right ear hole to give you the best viewing pleasure going forward, okay? Now, when we're holding it, as you can see on the top picture, if you're examining the right ear, you use your right hand. The handle of the otoscope needs to be held like a pencil, okay? So I hold it with my fingertips like a pencil. But you will notice that that right hand is also anchored using the small finger against the person's cheekbone or just underneath the cheekbone itself. And this is to help prevent any damage. Remember, we're dealing with kids. They're going to be moving around. Like anything, they want to be seeing what you're doing. So if they move, you want to be moving away with them as well. So you're not having to cause damage because you're not moving. So it helps you anchor. So with your left hand, you're putting up the ear pinner to strengthen the canal. With the right hand, you're holding your otoscope with the handle in the same direction as the person's nose. Right hand, right ear, with your baby finger against the person's cheek or cheekbone to anchor yourself appropriately. And that gives you the best viewing pleasure. You'd also need to make sure you're the same height as the actual otoscope viewer so that you're able to see without doing your back in and not having to crouch over, because you've got to look after yourself there as well. Okay. So I hope that's something that, gives you a bit of an idea of, when you're using it, get your pencil out, get your otoscope out, practice makes perfect. And the more people you see, the better it is. And you won't know what you're looking at unless you see more people down your otoscope lens. So assuming that there's no issues with your actual ear canal and the ear canal is free of debris and issues and any sort of potential inflammation, we then want to look a little bit deeper and try to view the tympanic membrane or the eardrum. And now this is shaped as an ellipse or an oval shape. It's very thin membrane, only 0.1 millimeter thick. So again, paper thin. The membrane is slightly inclined at about 45 degrees. To identify what we're looking at, it's important to be familiar with the landmarks, okay, of the eardrum. And it helps us not only identify the areas, but also effectively communicate what we see on the actual farm outcomes form that we have to populate, okay? So looking at from the middle onwards, okay? And I see the eardrum just like you do with the normal drum, like you're playing drums as a child, okay? You have a continuous sheet of thin membrane, okay? Starting from the middle, you got the umbo, okay? The umbo is attached to the handle of malleus, okay, which is that long emanating bone from behind protruding, okay? On top is your pars flaccida, okay? The majority of your membrane is called a pars tensa. As you can imagine, flaccid is flaccid and tense is tense, okay? So the tensor is quite a tense membrane to allow the movement of the sound waves to be picked up by the pars tensor, so it can be conducted further by the internal hammers and all the other bones that would then take it forward into the internal structure. The outside rim is almost like the drum rubber that attaches to the outside of the drum, which is called annulus, okay? And because we know, like with every drum, okay, the most tense part tends to be on the outside, the biggest area of depression tends to be in the middle. Where the umbo is, we get a cone of light emanating out, okay? And that cone of light is there simply because of physics. It's nothing, there's no light underneath it, obviously, or inside it. It's a reflection from your fiber optic otoscope that reflects at an angle because the area of depression, because it's concaved, you see, it's not flat, it's concaved. And as a result, you get a cone of light emanating outwards. So on the top left, you see a pictorial diagram of it. And on the bottom right, you see it superimposed on an actual tympanic membrane. Now, usually healthy tympanic membranes are very pearly gray under illumination, and they usually display a slight sheen, almost like a mother of pearl, okay? And it's important that, we don't disturb this, but we observe where these different parameters are and different landscapes are in order to demonstrate if there's any issues with either having perforation or having a foreign object, or if there's anything which would not look normal. This is why it's so important to get as much experience as you can going forward, because tympanic membranes in one person, which is healthy, compared to another person, it's like comparing pigeons and ducks. Both have feathers, both can fly, but it's difficult to distinguish unless you practice. Okay, so it's important to have that exposure and seeing as many people. What I've been doing a lot in my pharmacies as well as in the practice is patients who are coming in for ear infections and so on and so forth, and they might have already been prescribed an antibiotic or ear drops, I tend to say, well, let me have a look as well. Let me see what the doctor sees. So I get that exposure to see what their rationale was, what they saw, and to make sure that, I can see when something looks abnormal, when it needs to be addressed. So I guess when we've seen our normal presentations, we've seen the different parameters and with the different landscapes that we need to identify as part of that. Let's look at what we're doing as part of our PGD and clinical pathway. Well, we need to obviously ask pertinent questions, okay? We need to find out from our history, what's the onset, what's the nature, what was the severity, and what were the symptoms, okay? And what the patient might describe to you, oh, it's pain, it's tender, okay? You might have pain or tender moving the targus or the pinna, okay? You might have pain or tender moving the jaw or chewing. You might get a little bit of ear discharge. They might have a little bit of itch inside the ear canal. They might say they have got a bit of fever or might have hearing loss, okay? And how does it affect them on the day-to-day basis? Might affect their quality of life. Possible causes could be then considered and addressed, like, what happened leading to this infection or this inflammation or the presentation that you're describing. They might say, oh, I got hit on the head, or I fell down, or I use hearing aids, or I've been using hearing plugs or earplugs, or I've been going on holiday, or I've had recent head and neck radiotherapy. Okay, they might have had previous ear surgery, or they've been using those Johnson & Johnson's ear Q-tips and cause a perforation potentially. Okay, we also need to find out what other symptoms they might have. They might have like allergic dermatitis, they might have eczema, so they might already have something that might predispose them to infections in the ear as well. Because remember, the ear canal is just a continuum of the outside skin in terms of the risk of exposure to infections, as well as eczema that compromises their condition. But when we're looking at acute otitis media specifically, what are we seeing? Well, we need to obviously assess the ear canal, which we've done, and the tympanic membrane and the pinna, and looking at the lymphatic nodes around the targus area, also known as the articular area. Okay, what we might see when we're looking at someone's tympanic membrane is it might be red, it might be inflamed, it might be edematous, okay? And also there may be slight obscure in terms of debris, or might be a bit of pus coming out, okay? It might be the discharge that might be coming out could be either clear fluid, or it could be colored fluid, or it could be bloody stained, okay? There might also be signs of fungal infections, such as white strands, or small black or white balls, okay, which might be around the actual tympanic membrane as well, okay? So we also need to look for anything else that might resemble things like cellulitis, which is spreading beyond the ear. They might have cellulitis in other places. Obviously, it's a red flag because of the risk of sepsis in that individual, especially if they've got, if they're immunocompromised. Check out for any perforations in the tympanic membrane. I've got a few pictures to show that as well in terms of what a perforation looks like, depending on the type of perforation it is. Okay, so here, hopefully you can see, okay, that, well, can you see your landmarks? Can you see the standard landmarks of the handle of Malus? Can you see your umbo? Where is the cone of light, and you can see it's bulging out. We know already that the tympanic membrane normally is concaved. This is certainly not concave, it's convexed, it's bulging out. Something behind is causing it to push out, and that's that inflammation. Okay. So when we're looking at inclusion criteria, we know first we need to get consent for that individual to be observed, to be checked out. Are they under the age of 2, or if they're above the age of 1, do they have bilateral acute otitis media, and are there symptoms which is presented for greater than 3 days, or have they got severe symptoms? Okay, if they are under the age of 18 with otorrhea, okay, or they're older children, do they also persist with earache? And also for younger children, check out for any symptoms of holding or tugging or rubbing their ears, and generally not feeling well in themselves. They might be crying, they might be feverish, or they might not be eating well. And mom or dad or parent or guardian might be saying, my child normally plays their Xbox after school or whatever, they've not been playing anything, they've not been eating anything. Take the history from the parent, okay? But also look at what the patient is presenting with. So you've got your symptoms, but also you've got your objective testing as well through otoscopy and seeing what you say. Okay, red, yellow, cloudy tympanic membrane, loss of normal landmarks. Potentially, they might have loss of hearing as well because of the impact on the tympanic membrane. The people we don't see, okay, are those individuals who already refused consent to be seen, and we need to document that. If they are under the age of 1 or above the age of 18, if they're already immunocompromised, or if they've got long-term use of antibiotics, or if they've had previous antibiotics that have failed. But also, we want to make sure that those individuals with high risk who are significantly unwell with signs and symptoms of either mastocytitis or meningitis or any sort of intracranial abscess which might be coming, seen as a leaky ear, which is without color. Okay, any sort of paralysis around the facial nerve, and individuals with cholestoma. I'll show you a picture of what cholestoma looks like. Okay, and it's nothing to do with cholesterol and it's nothing to do with cancer, but it's called cholestoma. Okay, if it's not within our remit, we have to pass it on, and we have to be quite efficient and prudent with that going forward.
Sorry, Darshan, we are running quite over.
I know.
40 minutes over, darling. So if there's a possibility to try and wrap up, we might have
certainly.
to. Yeah.
Fine. No. Thank you. So these are some typical presentations of what other alternative symptoms or presentations may look like. So this is otitis media with effusion, where you might get glue ear for individuals, and those individuals with glue ear, they tend to get the fluid because they got poor drainage around the echinacea tube. It has to come from somewhere, and the weakest point in their system is the tympanic membrane, and they get continuous perforation, healing, and this is why they get grommets placed. Okay, what a perforation may look like. Okay, you may get total perforation on the top left-hand side. You may get partial perforation as a result of impact or injury, or you might get a perforation as a result of glue ear on the bottom right. So it's just basically the body allowing the fluid to come out without any issues. You might also see individuals with otitis externa, and otitis externa is common. 10% of patients tend to have otitis externa in their lifetime, usually as a result of having other issues such as eczema or diabetes, or if they've been on holidays such as warm, humid climates, or other sort of immunosuppression conditions as well. And patients who may have humidity in the ear as a result of wearing hearing aids or earbuds. Okay, so basically it's like a fungal infection as a result of humidity. This is a picture of cholestoma. Like I said, nothing to do with cholesterol or cancer, but it's cells that shouldn't be there. It's the accumulation of benign keratinizing squamous cells. Okay, and as a result of this, it increases risk of infection, recurrent discharge, and individuals, if they're not managed appropriately with the correct antibiotics in secondary care, may get sepsis or an impact on the actual hearing going forward. This is tympanosclerosis, whereby patients like, for example, with glue ear who get constant perforations, healing, get scar tissue. This obviously affects the patient's ability to hear because scar tissue tends to be a lot thicker, and it compromises the hearing going forward. And of course, as Helen mentioned, with wax, super common. Dark wax is old wax, lighter colored wax is new wax. Wax is important, but obviously if those individuals who keep using things like earbuds to get it out tend to produce more wax afterwards as a result, because it's a body's way trying to protect itself. Super important for the hygiene, humidity, and also bacterial prevention for our ears, because it's an entry point into our bodies. So wax is good in moderation. And of course, foreign bodies. So this is a patient who was seen who had a battery lodged in next to the tympanic membrane. And this is a person who came from overseas and had an insect lodged into the actual ear. And they had to take this person to A&E drain it with alcohol, which killed the insect, and then they had to slowly prise out that insect so that it wouldn't damage the hepatic membrane. Red flags, things you need to consider very briefly. Making sure that you're taking a history complaint, but the things that we might need to do is address meningitis, mastocytitis, abscess, and any sort of sinus thrombosis or facial nerve paralysis. But also there are other things that they might need to consider in terms of hearing loss, risk of sepsis, meningitis, like we mentioned earlier, and trauma. Okay. So our gateway point is obviously that, the person's coming in with a presentation, but also we can see it through the otoscope that is red, yellow, or clouded hepatic membrane with moderate to severe bulging and a potential perforation showing that the bulge has broken and allowed the release of what was bulging it in the first place forward. Okay, but as long as the patient's well and they're not showing signs of more serious illness, then we can then proceed with the gateway point going forward to find out whether or not this individual, is there a discharge or after ear perforation? If there is, then we can't give any ear drops because obviously it's contraindicated. We'd have to give them an antibiotic. But if the child is under the age of 2 with both ears infection, both ears are infected, and if, for example, it is both ears, then we would have to use shared decision-making process, whether based on symptom severity and how they are feeling, as well as how long it's been going on for. And if it's greater than 3 days, then amoxicillin. If not, then potentially we could just give them the lidocaine, phenolazine eardrops. Again, utilizing your target. So make sure that from a patient point of view that we provide them with self-care, and if it hasn't resolved or worked out, then they need to be seen pretty sharpish. I don't think I'll go to the case studies. I think that might be a bit much, Suki. Any questions maybe in the last 5 minutes? Sorry about that.
I think we've had lots of suggestions in the chat. Many people are asking whether the notes will be recorded. So
yes,
that will be
notes are recorded.
Yeah. There's really quite a lot of information that you provided. Thank you very much, Darshan. It literally could have been a mini series, to be fair. There was so much that you were sharing. So I think if there aren't any other questions, if you could go through them afterwards, and perhaps everyone could have a look at those questions, and if you could feed back to us, that would be great. I know the resources will be available on the NPA website, but I appreciate everybody's time. You've really been patient, and thank you so much for going through all of that information and sitting so patiently with us. I'm sure there is so much information overload with everybody, so I do urge you to go back to the resources, and when you get a chance, maybe chunk and check and go back and have a look at the videos in little portions, because I know my brain's an overload, and there is so much, there's such a wealth of knowledge. So thank you so much, Darshan. Thank you, Helen. Thank you, Artish. Everybody for being so kind to wait and being patient with us. Particular way.